So I will be showing few of the pictures. All the students, they may post their answers in chat box. Okay. So identify this X-ray and you all may post your responses in chat box. So you all are correct. Yes, this is pneumoperitoneum. Okay. Identify this radiograph. So few of you say pyloric stenosis, few of you say duodenal atresia. Okay. Any other differential? You all shall be at least attempting. So someone said pyloric stenosis. Okay. This is not pyloric stenosis. In pyloric stenosis, stomach would be distended, but it would not be double bubble. Okay. There would be single bubble. A hugely distended stomach with very sparse, very little gas downstairs. Okay. You all interpret this gas and put your complete diagnosis in chat box. Someone says mixed acidosis. Someone says primary metabolic acidosis. Okay, we will discuss that all. Someone says metabolic acidosis with respiratory alkalosis. Okay. 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 So you all have given your responses. So rest of people have just taken all the adjectives away. They are just playing safe. They're saying metabolic acidosis. Again, they may be saying metabolic and respiratory acidosis. Okay. So, so Jonathan and Remia, can you please tell me, and Mercy as well, why do you call it a mixed acidosis? You can just either like one of you can unmute yourself and explain me, or if you don't want to speak, you can put it in chat box, whatever way you are comfortable. Remia says winter popular PCO2 is still very high. No, PCO2 is not very high. Okay, it's almost I would say reasonable. 1.5 times BICA plus 8 plus minus 2, so it is within that range. So it's not really very bad. Okay, so you don't have an unmuting option, no issue. So it's a metabolic acidosis. PCO2 is not very much out of proportion. So if we say, even if you take actual bicarb, 1.5 times the bicarb, that makes it around 16 plus 8, that makes it 24, plus minus 2 is acceptable error. So PCO2 is within limit, I would say. Okay, as far as compensation is concerned. Okay, and someone said primary metabolic acidosis. What is primary metabolic acidosis? What is secondary metabolic acidosis? And how would we make a diagnosis of primary and secondary metabolic acidosis? Someone said primary metabolic acidosis. Rajiv, why do you say this is primary metabolic acidosis and not secondary metabolic acidosis? Rajiv. And what happens in secondary metabolic acidosis, Rajiv? What happens in secondary metabolic acidosis? So it's compensated metabolic acidosis, partly compensated by respiratory acidosis. Okay, so it's not there. It's not like primary metabolic acidosis. When you say primary metabolic acidosis, it means metabolic acidosis without any other issue like sepsis associated or stroke associated or CKD associated or diabetes associated. So if you don't have any explanation for metabolic acidosis, then you call it primary metabolic acidosis. Okay. Here, perhaps you mean primary disorder is metabolic acidosis. So you don't call that primary metabolic, you call that metabolic acidosis. Okay. Interpret this X-ray. Okay, someone says white out left lung, right side pneumothorax and left side white out. Left side lung is collapsed, left effusion and right pneumonia. I could not think that many things. Like if I was a student with this kind of X-ray, I might have not been able to think that much. Cardiomegaly, evolving pneumothorax, right side. What is evolving pneumothorax? What is evolved pneumothorax? When you say it is evolved now, left side effusion, right side pneumonia. Okay, so let's interpret this. So many of you have said right side pneumothorax. There is hardly any news. You can see lung marking all across, bearing like basal portion that seems little more black, but otherwise you can see lung marking over here as well. So lung marking is there on right side of lung for sure. So it's not right side pneumothorax. Okay. And then if you look at left side, yes, left hemithorax is totally opaque. You cannot differentiate lung from the cardiac border on left side. Okay, so what can be the differential? Either it's left-sided collapse or left-sided consolidation or left-sided refusion. Now, how would you differentiate between these three? Collapse, effusion, and consolidation. Okay, now just put those responses. How would you differentiate between these three? Forget right side. Right side is normal. Shifting of mediastinum in collapse. So is mediastinum shifted to left? Is mediastinum shifted to left in this X-ray? No. So no shift, that means collapse is out practically. Okay. Is mediastinum at its normal place where you expect it to be, or it's little towards the right? Rajiv says shifted little towards right, little towards right, shifted to right. So now you are convinced with my idea, okay? That seems like. Look, even I don't remember what condition this baby had when this X-ray was captured. Okay, this is very old X-ray, but yeah, if I am interpreting this X-ray in absence of baby's clinical assessment, this X-ray is like mediastinum either at its normal position or shifted little to the right. Okay, so it could be either effusion or it could be consolidation, but for sure this is not a collapse kind of situation. Okay, so consolidation or effusion, both differentials are fine. Okay, but not collapse and not right side pneumothorax. Okay, interpret the CCG. Interpret this karyotype. Good. Interpret this image. It's forest plot, but I want to interpret the findings, not just simply tell it's forest plot or not. Interpret the findings on the left side, on the right side. Interpret this. Interpret this result. This result and interpret this result. No one wants to answer. Interpretation of left side plot as well as right side plot. Okay, so no one wants to answer. Okay, let me explain you all. This is line of equivalence, one. Okay, and these are the odd ratios. So if you look at on left side, the upper bound and lower bound, the confidence interval of odd ratio are to one side. Okay, that means whatever is the outcome, the effect has the this has led to reduction in that outcome. OR is zero point 0.5 with CI being less, the upper bound of CI being less than 1. Okay, so this means intervention favors the results favor the intervention. If you look at the right side forest plot, the mean effect is towards the left. That means in reduction in outcome. But if you look at CIs are crossing. Upper bound of CI is more than one. So here you can't say that intervention is beneficial. On left side, you say the intervention is beneficial, but not on right side. So for this outcome, intervention is beneficial. For this outcome, intervention is not beneficial. Okay. Interpret this ECG. No one is answering. Complete heart block. Someone says first degree heart block. Why it's first degree heart block? Manisha, can you text? Why did you, Manisha and Sarfaraz, can you text? Why did you say it's first degree heart block? What happens in first degree heart block? What is the finding in first degree heart block? So in this case, you believe this only PR interval has increased, rest of things are normal. No. Here, atrial rate, these are atrial ventricular beats and atrial beats, they are independent of each other. Okay. So this is idioventricular rhythm. This is complete heart block. Okay. Is that fine? There is nothing like progressive increase in PR interval. P and R are independent of each other. Okay. So shall we stop here? Dr. Nidhi, over to you.
Yeah, thank you so much, Dr. Manoj Modi sir, for such an engaging and informative session. And I would like all the participants